Hello, my name is Robert Brantley, kinesiology student at Cal Baptist University. Today I'll be presenting three common injuries that occur in professional baseball. Professional baseball includes athletes at the major league and minor league levels. There's about 7 different levels of professional baseball that all average within 150 to 162 games in length in the regular season. This causes extensive wear and tear on the athletes and leaves them susceptible to three common injuries that are the rotator cuff tears, ulnar collateral ligament tears, and meniscus tears in the knee. Some environmental factors to be considered in professional baseball is the age range. Players' ages range from 18 to even well into their 40 years of age. The young adults tend to have that young elastic tissue, and like they're kind of in their prime, and they can handle the length of the season a lot better than the athletes that are in the later parts of their career at about 40 years of age that have uh, less elastic tissue, just because of their age. This included with the years of those seasons adding up and added wear and tear leaves them a lot more susceptible to those three common injuries. Professional baseball is a male-dominated sport. The female equivalent would be softball, but there's no professional organization, I believe, for softball. Baseball is played in all weather conditions, or I shouldn't say all, but in different weather conditions. Like rain is a condition that's tolerable. They will play, but it does create an unstable surface for the athletes, leaving them more susceptible to those meniscus tears. They play in cold climates that create an environment where the blood flow isn't as good as a warm climate with the vasoconstriction of the extremities, leaving them more susceptible to injuries of the rotator cuff and also their ulnar collateral ligament. Getting into the rotator cuff injuries, this can result in either partial or full tears. Partial tears is basically fraying of those tendinous tissues that commonly occur from repetitive overhead throwing, the overhead throwing motion, um, where the humerus grinds against the glenoid rim. Specifically, the supraspinatus is usually involved with this. If the athlete doesn't get it treated, it'll turn into a full thickness tear where surgical intervention is needed. The anatomy of the rotator cuff, it consists of 4 different muscles. The supraspinatus, the most commonly injured, infraspinatus, which is usually the second muscle to be injured, the subscapularis and teres minor. The supraspinatus originates on the medial 2/3 of the supraspinosa fossa and inserts on the greater tubercle of the humerus. It's the most superior of the rotator cuff muscle, just meaning that it's located right on top or articulates right over the top of the glenoid or glenohumeral joint. Infraspinatus originates on the posterior surface across the glenohumeral joint and assists in external rotation, horizontal adduction, extension, and stabilization. The subscapularis originates at the anterior surface of the scapular fossa, and then that inserts on the lesser tubercle of the humerus, which also assists in internal rotation, adduction, extension, and stabilization. And then finally, the teres minor originates on the upper middle aspect of the lateral border of the scapula and inserts posteriorly on the greater tubercle of the humerus. And that also assists in external rotation, horizontal adduction, extension, and stabilization. So they all encompass stabilizing that joint as they articulate around it. Mechanisms of injury for the rotator cuff muscle. The throwing motion is the main mechanism that causes this injury to to occur. The horizontal adduction with the internal rotating of the humeral head rubs the humeral head against the glenoid rim, especially when transitioning from the cocking to the acceleration phase, which is a forceful adduction through the diagonal plane of the arm. That violent adduction irritates the rotator cuff muscles and can cause the fraying or the full thickness tear. Assessments for rotator cuff injuries. A common assessment is the empty can test, which requires the patient to hold their arm out in extension about 45 degrees in horizontal adduction, where the arm is internally rotated to where the thumb is pointing down, resembling that of a person holding an empty can. The athletic trainer will provide a downward force to the patient's arm while the patient is trying to resist. A positive test will result in pain in the rotator cuff or in the shoulder, where the patient will usually be referred to get an MRI to look at the extent of the damage in the rotator cuff. Treatments for the rotator cuff, Graston technique can be applied. This is a good treatment because it breaks up adhesions and displaces scar tissue formed during post-operation, which helps increase range of motion, helps increase blood circulation to get that broken up tissue out of the area, increases blood flow, which also increases the transport of healing properties, and it's beneficial for the alignment of that new scar tissue that forms, helping the tissue to be stronger and for the shoulder to have greater range of motion. Preventative exercises for your rotator cuff. Banded internal and external rotations are popular exercise to develop the rotator cuff muscles, specifically the supraspinatus muscle. Bands are great because of their progressive resistance. At the start of the exercise, the band is at its most lax, and as the person executes, or the patient executes the movement, the resistance gets greater as the tension gets greater on the band. You want to secure the band to a stable device about shoulder height, with your shoulder in about 90 degrees of abduction and elbow flexed about 90 degrees, resembling that overhead throwing motion. You're going to externally rotate around the axis created by the humerus in the concentric part of the lift, and then internally rotate it eccentrically, guiding the band back down to the starting position. When you see the athlete or patient start shrugging their shoulders to compensate for the weight, this could either mean that their rotator cuff muscles are too weak or that it's still injured and they're feeling pain. In between doing these in between 2 to 5 sets, depending on whether it's an activation or maintenance, is going to determine the range of sets. 2 being activation. Getting into 5 sets, you're trying to increase the muscular endurance and stimulate increases in strength. 15 to 20 reps is a good rep range for this exercise because it stimulates muscular endurance. 3 to 4 times a week is more than sufficient for the development of those rotator cuff muscles. If the athlete's progressing, the athletic trainer or coach can add perturbations, which is a great dynamic stimulus for neuromuscular adaptations to improve the athlete's proprioception. The athletic trainer is going to apply random acute forces along the arm while the athlete's performing internal and external rotations. Again, if the athlete is shrugging or dropping their shoulders, this is an indication that they're too weak and probably not ready for this progression. Rep ranges are around 2 to 5 sets, 15 to 20 repetitions still within that muscular endurance range, about 3 to 4 times per week, allowing adequate time for rest on the subsequent days. Another preventative exercise, the Ys, Ts, and Ws are a great complex performed on a physio ball to strengthen the scapular muscles, which is an essential component to the glenohumeral movement in its kinetic chain. So the athlete will lie prone on a physio ball, holding that neutral spine position, and perform shoulder flexion, which will resemble the Y's, horizontal adduction, which will resemble the T, and scapular depression and retraction, which will resemble the W. Common faults you see with this exercise are the athlete swaying using their lower back to try and hoist the resistance up. This is an indication that their rotator cuff and scapular muscles, supporting muscles, are too weak, or they might still be injured. Doing this for about 3 sets is adequate for stimulating strength and muscular endurance. The repetitions are going to be 5 reps each in 5 sets each, totaling about 15 total sets in 15 total reps in the set. Performing this 2 to 3 times out of the week will be good for the maintenance of those scapular and rotator cuff muscles involved in the exercise. As an athlete, if an athlete wants to progress and do something more challenging for those scapular and rotator cuff muscles, the decelerated plyo catches are a great exercise. It stimulates the supraspinatus and scapular stabilizers. They're again going to be lying prone either on a table or a physio ball in the same overhead throwing motion, holding a weight ball, and then they'll perform quick oscillations of catch and release of the ball, forcing their decelerators to work. Common faults with this, you'll see them swaying to throw the ball up. This is an indication that they aren't ready for this progression. 3 to 4 sets. Repetitions here are best or is best calculated through time. So to complete a set, 15 to 30 seconds of these oscillations will be sufficient for activation about 2 to 3 times during the week. Rehabilitative exercises for the rotator cuff muscle. Pulley exercises are a common exercise used to restore range of motion and to build the concentric and eccentric strength back into the shoulder. The pulley is located anteriorly and superior to the patient. The hands are arranged so that a shoulder can be in max extension while the other is in max flexion, with their scapulars protracted and retracted respectively. This allows the normal shoulder to either aid in the range of motion in the rehabbing shoulder, or give it resistance for strength stimulation. Applying too much force to the injured shoulder can indicate that the shoulder wasn't ready for the stimulus and can cause re-injury. So that's something that an athletic trainer wants to make sure to inform the athlete in recovery. Performing 3 to 4 sets of this in between 5 to 20 repetitions. This is depending on their phase of rehabilitation. If they're just trying to restore the range of motion post-operation, be in the 5 rep ranges. If they want to increase the muscular endurance, you start getting into the 15 to 20 rep ranges. They can perform this 4 to 5 times per week in trying to reestablish that range of motion. Progressing from this, wall glides with a physio ball is a great progression, just because it puts the athlete through the same exact range of motion as the pulley exercise, but it does so under an isometric compression force, which encourages stability in the rotator cuff. The athlete will compress a physio ball against their forearm in 90 degrees of horizontal adduction of the shoulder and 90 degrees flexion in the elbow. They'll glide the shoulder through flexion and extension, rolling the ball against the wall. Lack of stability in the joint will show if the athlete can't maintain compression on the ball and they slide off. Performing this about 3 to 4 reps, or 3 to 4 sets at 15 to 20 repetitions in that strength and endurance range about 4 to 5 times during the week.